The topic which I will talk about is the reticular opacities in HRCT. In literature, reticular opacities are bronchovascular interstitium, interlobular interstitium, and intralobular interstitium. Other authors in literature also divided into interlobular septal thickening, honeycombing, and irregular reticulation. And today I provide another approach, which is just the interlobular septa, which I see it's sufficient to describe this topic, reticular opacities. The secondary pulmonary lobule is the smallest unit that can be visualized if pathological in the HRCT. The interlobular septa contains the lymphatics and pulmonary veins. The core of the secondary pulmonary lobule contains bronchiole and centrilobular arteriole. As you can see here, this is the lung. It's the smallest unit of it is secondary pulmonary lobule. They are hexagonal in appearance. The interlobular septal thickening, as you see here, if they are thickened, they bound the boundaries of the secondary pulmonary lobule, showing the thickening of the walls. And at the center, you'll see the centrilobular arteriole. Interlobular septal thickening is considered pathological with the certain conditions. They should be significant in amount if isolated, or should be the predominant abnormality in HRCT. They are not considered in the differential diagnosis if they are few and not fully outlining the secondary pulmonary lobule, which happens in normal subject, that you can see few of interlobular septal thickening, but not fully outlining the secondary pulmonary lobule, and they are very few in amount. And if they are not dominating feature, as you see here, they are very significant in amount. They are bounding the pulmonary lobules, forming the hexagonal appearance. Before proceeding to the differential diagnosis of interlobular septal thickening, we have pitfalls and mimickers, not to be mistaken as interlobular septal thickening. There are the perilobular pattern, there are the reversed halo sign, the crazy paving, and honeycombing. The perilobular pattern, which is mostly representing the perilobular organizing pneumonia. As you see here, it's more thickened appearance of the boundaries of the pulmonary lobules. This occurs due to consolidation occurring along the interlobular septa. They look thicker and they not sharply defined, as you can see in the interlobular septal thickening in the examples before. And you can see here, these are the perilobular consolidation occurring in the inner margin of the pulmonary lobule. These represent organizing pneumonia in most of cases. Another example showing the perilobular pattern of interlobular consolidation. These are not interlobular septal thickening. Another mimicker, which is the reversed halo sign, particularly is seen at the margin of the lung. Here it's easy to recognize this is a reversed halo sign. But here, if you see interlobular septal thickening and the core of the pulmonary lobule showing ground glass, so this is reversed halo sign, has different differential diagnosis compared to the interlobular septal thickening. but presence of reverse halocyon elsewhere in the lung will make it easy for you. But if it is only confined to the costal margin, and it be a mimicker for interlobular septal thickening, take care of the irregularity of the thickening, which is thicker here, as it is a consolidation, perilobular consolidation, and the core of reversed halocyon. Another mimicker, which is the crazy paving, it's bounding of the secondary pulmonary lobule by thickening of interlobular septal thickening, but presence of ground glass within the secondary pulmonary lobules. It gives appearance similar to the crazy paving. It occurs as in this pattern. Initially, it is ground glass opacities within the lung parenchyma, with interlobular septal thickening bounding it, giving this appearance. Areas of normal lung beside areas of ground glass opacity bounded by interlobular septal thickening, and sometimes it shows also intralobular septal thickening as shown here, and it's popular for the pulmonary alveolar proteinosis, first described in this entity, but later on it can be seen in any entity causing acute or chronic ground glass opacities. Last mimicker is the honeycombing, and if you have chance to listen to any of my lectures about fibrosis, you will find the differentiation is easy. These are truly cystic changes. They are thick-walled clusters of cysts. They are stacked together along the costal margin. But here in the lung bases, you see them very extensive, and they are sign of fibrosis. Interlobular septal thickening is not a sign of fibrosis unless it is irregular reticulation. But interlobular septal thickening is not fibrotic feature per se. These are honeycombing cysts, thick-walled, air-filled, stacked along the costal margin, and they are almost rounded, not bounding the pulmonary lobules. The interlobular septal thickening in the next video are divided here into smooth thickening, which is the most common, nodular thickening, and irregular thickening. In irregular thickening, it will represented in fibrosing lung disease. See you in the next lecture.